Hello, welcome again to ARI 2024, and this time we have a very interesting satellite session on CAPSULaser about automatic capsulotomy in the clinical practice. Automatic capsulotomy is one of the holy grails that we have in cataract and lens surgery, and indeed today we are going to cover this topic with the kind support of the CAPSULaser system, which is a technology in which we have been working for several years already, and is one of the real promises for real surgery in order to implement the practice in and its use in cataract and lens surgery. I want to thank this panel that will be transferring to everybody, listening to us the experience and the details about this new emerging technology and how to make it useful for your patients. We start with an introduction by Peter Stodulka, who is co-chairing with me this session about CAPSULaser, capsulotomy, and how to optimize this technique. Pavel, you are the first speaker. Thank you.
Hello, I am Pavel Stodulka, and I'm going to talk about CAPSULaser, the world's smallest laser for cataract surgery. At the same time, I would like to introduce a dark spot on anterior capsula, which we called center trypan landmark, which we discovered while searching for optimal capsule staining and optimal capsulotomy centration for CAPSULaser. How does it work? 590 nanometers laser absorbs in stained capsula, cuts it, while thermally unwinds type 4 collagen and converts it into amorphous collagen. We have achieved several milestones during this development, and the main milestones are significantly shortened capsulotomy time from 3 seconds at the beginning to 0.3 nowadays, so it's really a fast capsulotomy. And we center capsulotomy according to this trypan landmark on the anterior capsule.
A circular opening in the lens capsule is a gate inside the lens for cataract surgery. The most common way to open the capsule is a manual capsulorhexis. Handheld forceps are introduced through the main or side port incision to punch the capsule and create a circular opening in it. Capsulotomy can be performed by laser with the promises of high precision. Current femtosecond lasers are bulky and expensive and usually require a dedicated operating room with strict air conditioning control and additional patient manipulation. We have developed a compact and cost-effective device called CAPSULaser, which is mounted under the surgical microscope and performs capsulotomy in 1 second. The capsulotomy procedure is fast, precise, and reliable. The capsular edge is very firm and elastic, and significantly more stretchable compared to manual capsulorhexis. CAPSULaser is a small device with the delivery system mounted under the surgical microscope. After the trypan blue was washed out, the anterior chamber is filled with OVD. We have used this device in over 50 eyes and obtained a complete circular capsulotomy in all cases. CAPSULaser capsulotomy is a promising new way to perform laser capsulotomy and can make laser capsulotomy much more easily available worldwide.
Our clinical work with capsulotomy led us to a discovery of center trypan capsulotomy landmark, which we use for capsulotomy or capsulorhexis centration. How do we create this dark spot at the anterior capsula? We stain it with 0.4 microfilter trypan blue for about 1 minute, and in 94% of patients aged over 50, we see this very nice dark spot right in the center of the capsule. Why does capsule stain more in the center? Well, it well correlates with the capsule thickening over the age as published by Packard and as we see at the right-hand side of this slide on the chart. So now we have described the central capsule landmark. What usage? Well, we thought perhaps it can serve for capsulotomy centration. We have created a clinical study comparing capsulotomy centration according to a dilated pupil and according to this central trypan capsule landmark. We treated 117 eyes divided into these two groups. Group 1, centered according to dilated pupil. The mean deviation from visual axis was 0.24 millimeters, and the capsulas just covered the IOL optic a little bit asymmetrically, a little bit more often. The second group was centered according to the trypan central capsule landmark, and the mean deviation was 0.14 millimeters, which is about 1/2 of the previous group. And we have observed that the IOL optics were covered really symmetrically by capsulotomies.
The dye is washed out by BSS or Ringer solution. And the anterior chamber is filled with OVD. The blue center is a landmark for capsulotomy centration. CAPSULaser is a compact laser with a delivery system mounted under a microscope, which fits all different types of surgical microscopes. The laser performs capsulotomy in only 0.25 seconds, with a diameter from 4.0 to 5.5 millimeters in 0.1 millimeter increments. The contemporary version requires no surgical contact lens, which makes the procedure very straightforward. After the centration and focus, the circular capsulotomy is done. The central capsular disc is aspirated directly by the phaco tip.
Now I'm going to show a really interesting clinical case of CAPSULaser capsulotomy on eye with intumescent cataract. You see how fast, safe and effective the capsulotomy in a fraction of a second is, and there is no need for central capsule opening to release the pressure of such intumescent eye.
We see a nice laser capsulotomy, easy to remove the central capsular disc by microforceps. The strong blue capsulotomy edge is a safe fundament for cataract surgery.
In conclusion, CAPSULaser provides a capsulotomy of a given diameter in a fraction of a second. It has multiple users from Europe all the way to South America and Australia. It's CE-marked, and it's the only laser with no PI for cataract surgery. The procedure is easy and fast, and centration according to central capsule landmark provides the best possible capsulotomy centration. Thank you for your attention.
Thank you very much, Pavel, for this very nice and practical presentation. And now we have a presentation by Richard Packard, CAPSULaser in action. Please, Richard.
I'd like to thank Professor Jorge Alio very much indeed for asking me to take part in this session on CAPSULaser. My title today will be CAPSULaser in Action, an Overview. I am a consultant to the company Excellens that make the laser. So how does CAPSULaser work in complex eyes? You've already seen from the previous presentation what is required in standard eyes. So let's have a look at intumescent cataracts zonular issues, small pupils, capsular fibrosis, and corneal changes. Let's start with intumescent cataracts. CAPSULBlue certainly helped, as we know, but seeing the capsule was only part of the story because of the intralenticular pressure in intumescent cataracts. The original Argentine flag sign was described in 2000 by Daniel Peroni, and we can see his original slide from his original video here, and also that he felt very patriotic in this regard and felt the need to salute. Selective laser capsulotomy using CAPSULaser is a useful approach. First of all, we're going to prepare the eye for the laser. Let's see how we're going to do this. We're going to inject microfiltered 0.4% CAPSULBlue. You can do it either with an air bubble or without. The important thing is to get good coverage on the capsule, leave it for 60 seconds, and then it requires a very thorough washout of dye. So the only place that the CAPSULBlue is left is on the capsular surface where the laser is going to be applied. Now you backfill with a sodium hyaluronate or similar OVD, which is optically clear. It's important to overfill the anterior chamber, as you can see here. So the sequence is to turn on the laser, focus it, center it, pause, and then activate. Let's see that in the video now. So the laser beam, aiming beam is on, it's focused, it's centered, and now fired. You can see with this intumescent cataract that there is shrinkage of the cap and expansion of the capsular opening. And when you remove the free cap, you'll see that, in fact, there is no lens matter coming forward into the anterior chamber. This is because of the pressurization effect of the high molecular weight OVD. Small pupils do not present a problem. Here's an example from Professor Alio. Going to do a pupil stretch, and then the size of the capsulotomy will be adjusted to 4.9. You can see that here. This has now made a good capsular opening. Here's another small pupil case with zonular weakness. This is a pseudo-exfoliation. Now see the capsule has already been stained, so we're now going to stabilize the eye with the ring, and having focused it, we will then allow the laser to work. The pupil size is going to contribute as to what size we can make the capsulotomy. As you can see here, it's certainly been reduced, but within the size of this pupil, we've got a good opening, which will mean that the surgery can go forward without any great difficulty. Here's an example now combining in intumescent cataract a small pupil and fibrosis, and you can see we've got the pupil expander in place. Now I'm going to go in and remove the cohesive viscoelastic that's been put into the eye in order to get the pupil expander in place. It's very important to remove the OVD. Because it's cohesive, it'll come out fairly easily, and then inject the dye as you've seen before, slowly allowing it to settle onto the anterior capsule. You will have left it there for 60 seconds. It's now being thoroughly washed out, and you can see that the central area of enhanced staining is now apparent. A little bit more washout, and now fill the eye with the optically clear OVD, and now turn on the laser, focus it, center it in the middle of the area created by the pupil expander. Now you can see here, because of the fibrosis, there are some tissue tags, and these will need to be separated. But that's fine, because you're still going to end up with a nice capsulotomy with a good strong edge. The tags are not going to interfere with this. You can just use your Sinski hook to assist in separating that. Got another tag here. When we turn the capsule cap over, you'll see there is the fibrosis underneath. And finally, we're going to get the last little bits out. And what's amazing is at the end of all of this, because of the OVD being in the eye, the lens material has stayed put. It's not come forward at all. Now what happens when you've got a corneal change with the selective laser capsulotomy? We can see these changes on the cornea. There's a scar there. Going to go in now. We've got the dye in, which is being washed out. You see the scar more easily now. And once we got it washed out and we've got the OVD in place, you'll see what happens when we turn the laser on. It's now beautifully centered on the enhanced staining area, and it goes round. Now there is an incomplete cut here. You can see where the cut is not complete. This is because the scar has interfered with the passage of the laser beam. But when in fact, when you go into the eye, you'll find there's enough of a cut there so that it is possible to peel this away and still get a beautiful round and centered capsulotomy. You can see this is absolutely as you'd want it to be, and that the corneal scar really hasn't had any adverse effect here at all. So in summary, selective laser capsulotomy with CAPSULaser is a safe, predictable means of creating a strong-sized, circular and centered capsulotomy. CAPSULBlue provides excellent capsule staining with 60-second exposure to the capsule. The trypan central landmark with CAPSULBlue offers a means of accurate centration without the need for patient fixation. And CAPSULaser is useful for consistent capsulotomies in more complex cases. In either with intumescent cataracts, CAPSULaser provides the technology for minimizing unexpected capsular tear-out. Thank you very much for your attention.
Thank you, Richard. And indeed, it's true that for special cases, CAPSULaser works very well in my experience, definitely confirms that. And now we have David Mordaunt, who is the physicist who invented CAPSULaser, who is going to talk to us about the centration of CAPSULaser, and later on we'll go to the practical tips provided by users of this technology. So now, David, you are the next speaker, and thank you for being here today.
Precision capsulotomy centration, 180i study. Why is centration of the capsulotomy important? I think we all realize that a nice robust capsulotomy can be a great foundation for surgery, but also for the IOL as postoperatively. We know that if it's decentered and there is incomplete coverage, this can lead to early onset PCO and even asymmetric fibrosis, which can lead to IOL decentration and tilt. This is important for all IOLs and patients, but optically, multifocal IOLs and torics are obviously going to be more sensitive to decentration and tilt. The goal for capsulotomy is quite simply to be centered on the IOL. And hopefully this yields a nice symmetric 360-degree coverage, and that's what we'd like to achieve. But it's kind of a chicken and an egg scenario. Where will the IOL be located in the eye? And then what is our target? Because obviously we're creating the capsulotomy first, but we want to center it on the IOL. So the only real way to address this is with a little bit of intelligent thought, looking at all the options and conducting a clinical study to see what plays out. So this is a 180i prospective case series. We have 3 arms: pupil centration, trypan capsular landmark centration, which Pavel talked about earlier, and the coaxial Purkinje image as our centration landmark. There are 3 groups: pupil centration, centered on the dilated pupil; trypan capsular landmark centration, centered on the dark, intense capsular stain; and 3 being the coaxial Purkinje image centration group. We basically see wonderful correlation between the Purkinje images and the trypan landmark. Well, now in the statistics, and for an anatomical system, this is a very significant correlation. What we'd like to see, of course, is a nice capsulotomy centered on your Purkinje image or your trypan landmark or on the pupil, and all yielding a nice IOL centered on the capsulotomy. In the study, we had a small number, about 5% of eyes, that actually achieved all 3 criteria. Interesting. So that, there's obviously some very symmetric eyes out there, but it's not every eye. And I think we need to look at beyond the 5%, the 95%. So now if we use the group 1, that we have asymmetric IOL coverage. We have IOL coverage in all situations, but we actually see the decentration, and we can see it's actually somewhat random. It's not predominantly nasal, superior, it's kind of all over the place, and this may well be due to the fact that the pupil dilates asymmetrically, and there isn't a strong anatomical preference. As we'd expect, we can see the decentration of the pupil center relative to the IOL. These types of capsulotomies, there is a high degree of decentration between the IOL and the capsulotomy. The average is 0.3, but there is a range. And as we kind of go towards the edges here, 0.5, we're also at the edge of the range. And this might be more of the example of this IOL here, where we basically have a 5mm capsulotomy, 1mm on one side, and virtually nothing on the other side. And of course, this may have some tilt and instability long term. We look at the second group, the trypan capsule landmark centration. This yields excellent symmetry for the IOLs and capsulotomies. We can see here the Purkinje images in the patient with the IOL in the central region of the multifocal lens. Very high correlation as you expect, half as much decentration as you would see on pupil centration, a much tighter distribution, and the maximum displacement being 0.3. We move on to the coaxial Purkinje centration group. We see, again, very similar symmetric IOL coverage, and the statistics are very similar to those reported previously. And just looking at the decentration of capsulotomies relative to the IOLs, we can see here the range on the left-hand side being favorable and then becoming more decentered to the right. And using group 1 as the control group, we can see that both the coaxial Purkinje image is superior to pupil centration, and the trypan landmark indeed is also superior, and these two are equivalent. So some nice statistics here with a p-value of less than 0.05. To verify the results, we used Callisto Eye, but reference matched the IOL master data. So here is shown the visual axis as measured by the IOL master, and then we have superimposed on here a diameter of 5mm and then 6mm. A way of thinking about these two sizes is that the 6mm represents the optics body, and the 5mm represents where ideally the capsulotomy would be located. And we can see for the pupil-centered group, we do achieve some nice centration, absolutely, in some eyes. But in the majority of eyes, we see decentration, and actually quite major decentration here. This is what we were seeing in the other images, that when the IOL is there, 6mm optic body, the capsulotomy can be very close to the edge. Now, looking at the trypan capsular landmark group, we see excellent consistency with the capsulotomy actually being centered on the visual axis and 5mm being achieved. And this is what we're seeing with the IOL body too. It's nicely spaced around here, allowing for some deviation, and indeed here we have slight deviation, very minor, and I think we'd all be happy if we had that as well. The coaxial Purkinje image group, again, same story as for the trypan group. Excellent correlation with the capsulotomy being centered on the visual axis. This is not what we intended, but this is what the data shows us. So it's showing us that the IOL is actually quite predictive to be on the visual axis, and intuitively we know this because multifocals and torics would not work that well if that did not occur. Just have a look at some capsulotomies here. We'll actually look at a full case in a moment, but the capsulotomy is in 1/3 of a second, centered on the trypan landmark. If we look across a varied range of cataract patients, we can see we can still get excellent centration, independent of whether they be premium lens patients, all the way through to nice white cataracts, or pseudo exfoliation patients, small pupil, weak zonules. This is actually a multifocal toric, planned and used, and great visual outcomes at the end. Kind of an incredible thought process to be going from premium precision in this type of patient. This is enabled by using true centration, i.e. Purkinje images, or the trypan landmark, with laser precision, gives you a centered IOL coverage with the capsulotomy for long-term visual acuities. Thank you for your attention.
Thank you very much, David. This is an excellent evidence about how centration is implemented in our surgery, and now many details which are practical are going to be discussed with the discussion, the debate with the users. And I want to thank the presence of Andrew Dimitriev, Tim Schultz, Matt Russos, and Milton Yogi. That all of them will contribute to our knowledge about the practical application of this device. And the first, Andrew Dimitriev from the United Kingdom, is offering to us his details about the capsulotomy with CAPSULaser. Andrew, are you there?
Dear ARI 2023, my patient was an 89-year-old male with light perception, and he was not suitable for general anesthesia. After paracentesis, lidocaine and suprarenin were injected. Next, CAPSULVisc was placed on the cornea. Next, CAPSULBlue was injected into the anterior chamber. It allows a very intense staining of the anterior capsule. After 1 minute, balanced salt solution is used to rinse out the color. The anterior chamber is slowly stabilized with CAPSULVisc, a special OVD. After aiming, the anterior capsulotomy is shot with a CAPSULaser. As you can see, the diameter was on the fly adjusted to the stained area. A Koch forceps is used to remove the capsule disc. In comparison to femtosecond laser cataract surgery, I'm not doing the dimple down maneuver. After minimal hydrodissection, the size of the anterior capsulotomy was confirmed, 4.6 millimeters. As you can see, the CAPSULaser was removed from the optical pathway, so the colors changed. Phacoemulsification was started. However, due to the loose zonules, I was not able to break it. OVD was again injected and 4 additional incisions were made. The MST capsule support system was implanted. In my experience, the CAPSULaser produces a very strong capsulotomy, especially in white cataracts. Uncomplicated phacoemulsification was performed. After hydropolishing the posterior capsule, OVD was again injected and a single-piece IOL was implanted into the capsular bag. However, after removal of the capsule support system, I was not happy with the stability of the capsular bag. So OVD was again injected and the capsule tension ring was implanted. As you can see, I was very thankful for the CAPSULaser capsulotomy stability. Finally, the IOL was positioned, OVD was removed, acetylcholine was injected, and the eye was closed.
Thank you very much, Tim. And now we have the case of Matt Russell from Australia. Please, Matt.
Hi, I'm Dr. Matt Russell from Vizon Laser Eye Surgery Centre, Brisbane, Australia. Today I'm going to share my favourite lens surgery technique, which is to use the CAPSULaser laser-assisted capsulotomy technique to implant a Femtis MF15 toric IOL. I perform the cataract surgery using the Zeiss Callisto system. I correct the main incision and the paracentesis before performing any other part of the procedure. Then I coat the cornea in the capsule gel before inserting the high concentration trypan blue. Now, creating the main incision at the beginning of the case allows me to efficiently remove the trypan blue after 60 seconds of staining the capsule. Now, it's very important to be mindful of the anesthesia and sedation. I prefer to have the patient lightly sedated at the beginning of the procedure and perform the procedure under topical anesthesia. Avoiding deep sedation until after the capsulotomy has been created is important because you may get heavy respiratory motion or maybe a head movement that might decenter the capsulotomy. What you can see is a fairly dense staining of the capsule, but you will notice that there is a hyperintense circular area centrally that's an important landmark. The center of this area can be used as a guide to the line of sight. Achieving excellent centration is perhaps the most challenging portion of the CAPSULaser technique, but I also align this with the central area of hyperintense staining. And now you can also use the patient target light in the laser, or you can use the Purkinje images to assist alignment. In most cases, the capsulotomy separates cleanly. There are some cases where there are tags attached to the capsulotomy and surrounding capsule, which can be managed with the capsulorhexis forceps or an Agahoshi cannula, such as in this case. The capsulotomy is robust, but it's really important to remember to gently hydrodissect to avoid prolapsing the nucleus into the anterior chamber and avoid the possibility of any anterior capsule tears. You can see in this case it's quite easy to remove a whole hemming nucleus through the capsulotomy without any significant stress or risk to the capsule. And being a very experienced cataract surgeon, I really do like the staining of the capsulotomy. I just think this adds another element of safety to the whole procedure. In my experience, anterior capsule tears are very rare. The capsule strength is more robust than the capsules in flak surgery in my experience. You can see it's quite possible to do bimanual IA without shifting hand position. The Femtis IOL is injected with a one-handed technique directly into the capsule bag without any additional viscoelastic. The irrigation cannula is being used as an AC maintainer. There are no endothelial concerns here because the IOL never is near the posterior cornea. At this point, I'm positioning the implant optic into the capsulotomy, a technique called enclavation. I maintain the AC using the infusion cannula and use a short Sensitive hook. The technique is to position the most proximal anterior flange first. If the IOL is toric, I rotate the intraocular lens to the appropriate axis, then position the second anterior flange. The secondary flanges are adjusted, and following this, the toric axis is aligned perfectly using the Callisto guidance system. Really, at this point, you can begin to see some of the huge advantages of the Femtis platform in combination with the laser capsulotomy, and that we can perfectly orientate the toric alignment of the implant. Stability of the toric alignment over the long term is excellent. The ability to center the implant on the visual axis may also improve the quality of vision. Having the implant closer to the iris reduces negative dysphotopsia. And we've found that the EDOF effect of the Femtis platform is better overall than that of the Lentis platform. All of this results in what our ultimate goal is to achieve a high level of patient satisfaction. So our patient-reported levels of satisfaction are 96%, either satisfied or highly satisfied with this surgical technique and implant platform. We market this as a premium cataract surgery, but we term it laser cataract surgery, which I think really captures the patient's imagination. We're also able to charge additional fees above the standard cataract surgery fee for this surgery. There are many nuances to this technique that can't be covered in a short video. I'd just like to say that I'm extremely grateful to Pavel and David Mordaunt for developing the technology, and I'm also grateful for my colleagues who have shared their techniques to enable me to evolve my own. I hope this video can serve as a launching platform for your expanded approach to presbyopic correcting lens surgery, particularly in patients who want a high level of spectacle independence but are hesitant about lens replacement or premium cataract surgery because of night vision quality issues.
Thank you very much, and it was a great case, Matt. And now we have Milton Yogi from Brazil, who is going to show to us CAPSULaser in one clinical case. Thank you.
Hello, my name is Milton Yogi, and I would like to present the first 3 cases of CAPSULaser in our country. I would like to thank for the invitation by Dr. Alio and Dr. Pavel. I also would like to disclose the non-financial support from Telion, the Brazilian distributor Visionline, and the technical support of CAPSULaser. Well, the first 3 cases were interesting because the first case didn't dilate very well, but anyways, I decided to proceed with the surgery because I wanted to see how the CAPSULaser would behave. As you can see, the dilation was not that good. This is to show off the inverted V-sticks for laser focusing, which is very easily done. And remember, it was my first ever case. And this video shows off in slow motion the area, the untreated area in which the stain was not very good at the left. And in this slow motion video, we can see the laser not performing the action in the left area, but it was very easily solved and it presented no challenge at all. I proceeded with the surgery and it was very easily done. The second case, it had a much better dilation, as you can see, again in slow motion, but in this case I wanted to zoom in to show the edges of the rexes in much larger detail, as you can see. And other than that, I wanted to test in the second case the strength of the rexes. After I inserted the IOL, and in this image you can check the edges, but after inserting the IOL, I used my hooks to see the strength and elasticity of the rexes. Again, just pushing to check the strength of the rexes, and it proved very nicely. And the third case went by the book, and I took the flap of the capsular rexes and placed it on the top of the cornea just to show the roundness of the flap. So these were my first 3 cases in Brazil. I would like to thank the technical team and my fellows. What I concluded is that in these 3 cases that the procedure is quite simple, very safe, very repeatable, and very precise. Well, the learning curve is almost non-existent. You just follow some basic instructions from the technical team and you're good to go. It's simple in terms of there's no delay in the routine workflow, different from a femtosecond, which it's quite cumbersome when compared to CAPSULaser. And a point to stress out is the strong rexes that it provides. So I would like to thank my team and also the support personnel of the companies. I hope to see you soon in Brazil as well in our Brazilian Congress of Cataract and Refractive Surgery. Thank you.
Thank you very much, Milton. And now we have a time for a debate, 5 minutes, in which we shall have the opinion of the speakers. And in my opinion, this is a very important part because it's the real experience. Pavel and, well, friends, we have now both Pavel, we have Andrei Dimitriev, and also Tim Schultz. And my question to you is, which are the differences that in the practice of cataract surgery you find using CAPSULaser? For instance, the management of cortex is kind of different. We need to optimize the size to what we need, but we can optimize the size to a very large amount of diameters. Which are the main differences that the new surgeon using CAPSULaser can find when facing the first cases with CAPSULaser? Pavel, you are one of the most experienced, so I would like to start with you.
Thank you. Thank you for inviting us, Jorge. Well, I think, because I do a lot of femtosecond laser cataract surgery, but I prefer more and more CAPSULaser because it's more straightforward, easier to perform. It's a better, workflow. You don't need to manipulate the patient through one room to another room or to manipulate with the patient from the laser under the microscope. And at the same time, it provides the best capsulotomy in regards of strength and mainly centration. And I think this is super important, especially with the trifocal lenses, with EDOF lenses. So I really like that. And I think it was really nicely demonstrated by both Andre and Milton, how strong the capsulotomy is. I think Andre just pushed the eye with the capsule ring all the way outside of the microscope view and of the screen, just demonstrating nicely how firm this capsulotomy is to withstand that pressure. So I think that's very reliable. And we also have this edge blue stained, so it increases the visibility for the challenging cases. So to me, it's it's straightforward. I think you can build a very nice business model over that. Patients like to be operated by laser. And it's so much easier compared to the femtolasers.
Very good. And do you find tags to be frequent in your practice, Pavel?
Well, they are not frequent at all, but we can see them sometimes. But you just pick up the capsula with your endoforceps or capsulorhexis forceps and get it out, or you can even simply aspirate that central capsula directly with the phaco tip. So it's not a clinical problem. As long as you stain the capsula properly, you get a very nice cut.
Very good. Tim, you have shown a very interesting case, especially difficult, in which you use the CAPSULaser very successfully. Do you use regularly in these special cases CAPSULaser, or do you reserve them for the normal cases?
So at the moment, I love to do both. Regular cases, we have the huge advantage for premium IOLs with the mountaintop sign or this landmark we can see. This is still something new, and I'm happy that we saw now the first part of evidence, and hopefully we will get some more, that it is a new tool that we haven't had before for centration. So this is a part for the regular, easy cases. We can improve a lot, especially with premium IOLs like multifocal and toric IOLs. And the other part are, and this is one I love, that's why I choose this case, you always have it on your microscope, and you have this super complex cases like the one I showed. You always have the option, okay, just bring it in and use it, just to do a case that maybe is with hand impossible. So I'm not sure if I would have been able to do a capsulotomy in the case I showed with my hands. Maybe I will have lost the few zonules he had, and we have so many cases of this. It's maybe several a week, so it helps a lot in my daily routine.
Very good. And which is your favorite diameter, Pavel, for the CAPSULaser regular technique?
We typically go with 5.2, but with such a perfect centration, you can even enlarge to 5.5 because, you know, it fits so tightly. And I would like to point out also that there is no better tool for intumescent cataract capsulotomy than CAPSULaser. It's in a fraction of a second, 0.3 seconds, done. And, you know, all the milky stuff starts to go out, but it's already finished. So I think this is just the best tool for intumescent cataracts.
Okay, 5.2. Tim, which is the diameter that you use more frequently?
So in regular cases, I go to 5.1. I have the feeling that we end up in this case because it's enlarged a little bit, maybe at 5.2, and that's fine for the premium IOLs. And the good thing in the complicated cases, pseudoexfoliation, it's just, I just adjust it to what's possible. So just to get the cases done. Because sometimes you have a small pupil, and as I showed, I will always adjust it to the part where I have a good staining to get a good capsulotomy on the fly.
Thank you. Andres, you were the last one, and we couldn't see your case, but which is the diameter that you usually use in capsulation, your capsulation cases?
So my default is 5.2 indeed, but it's really unbelievably easy to switch to anything lower than that for small pupils, for pseudoexfoliation patients, and you can easily adjust it while you see the ring on the table, and you say, how about if I reduce it by 0.1 or 0.2? There's nothing easier to be used so in such complex cases. But at the same time, I would like to point out what Pavel said before: intumescent cataracts. You know, we all had these problems with Argentina flag sign, and suddenly it's just gone. It's completely gone. We forgot how it looks like. So we see so many cases in Poland right now, patients coming from Ukraine with intumescent cataracts, and you can finally have a very safe and perfect solution using multifocal lenses, using EDOF lenses with perfect centration, perfect alignment of the lens. I'm using variant system, sometimes double checking whether the centration, and it's so perfect with Triplan Blue centration as well.
Okay, so thank you very much. And well, we are out of time. David, anything else that you would like to mention about the future of CAPSULaser implementations and anything else that you consider interesting for us, CAPSULaser uses and future CAPSULaser uses as well?
You know, we've shown the centration and trifocals. What we have seen is some actually, we are looking at the visual acuities, especially uncorrected distance to visual acuity, and we do see an improvement there. We haven't reported that here because we want to do a multi-center study to really prove that out. But if that is true, I mean, intuitively, you know, when you have a centered capsulotomy, you get no tilt and it's centered on the optic, you minimize dysphotopsia, and you give the most stable foundational support for the IOL. I think that is the potential new future that's in the near term in our research. So indeed, that's kind of where we're focused right now.
Okay, very good. Well, thank you very much. Thank you for being with us today. This session was fantastic for those that are at the beginning of their practice with CAPSULaser. I strongly encourage all of you listen to this session to try and to be convinced that this is the future of our practice, automatic capsulotomy. I want to thank all the speakers and friends and David to put together this session and to CAPSULaser for the sponsorship. Thank you very much. Bye-bye. Thank you.